Well, while she's clicking on that, would you like to go ahead and kick us off, Katie? And then we'll pick her up.
Absolutely. I'm really excited to be here today talking about resources and programs and tools for women and families. I'm going to talk a little bit, I guess, myself. I guess I'll just start. Oh, we have a few other people popping in here because I know our time is limited. And I am I just successfully defended my dissertation. So I'm very happy about that. I just completed my doctoral studies at the University of Delaware, but I also work as a nurse practitioner in the fields of infertility and women's health and hormone replacement. So really a little bit about the research that's happening at Delaware in regards to women's health and tools that are available for women. My focus of research is actually on fertility knowledge in young women of reproductive age. And what we know is that, up to 90% of participants in various studies looking at fertility knowledge want to be pregnant at some point in the future. They want to build families. However, many times significant gaps in knowledge actually exist in women. They just don't really understand reproductive health. They don't understand the impact the age has on fertility necessarily, or when in the menstrual cycle fertility is at its peak. So there's a few other gaps that we're going to talk about in a second. But one thing that we do a lot of times in the research is that we lump women of reproductive age together. We take women from the ages of 18 to 49 many times to look at their knowledge. And I can tell you myself, as someone who's in my 40s, I know a little bit more now than I did maybe when I was 18. So, looking at these gaps in knowledge and being able to help women throughout their lifespan is really important to me and our program of research at Delaware. And why these gaps exist is another question that I like to ask, because as a provider, we are supposed to talk about fertility and have conversations with patients about developing what's called a reproductive life plan, or really it's a blueprint to talk about what someone's fertility goals are. And unfortunately, these conversations don't seem to be occurring, even when asked. Participants throughout various studies report that most of the information they get about fertility and pregnancy is from the internet. So what I was able to do with my own program of research was actually Dr. Corcus was involved with it, which was very helpful. We basically developed or adapted a tool looking at fertility knowledge in an at-risk group of young adults, so 18 to 24-year-olds. Fertility is at its peak during this time, so it's very important to understand what is known by this age group. And so my research was looking at developing this tool that hopefully can be used in various settings, in research, in healthcare provider offices, in visits with your doctor, just to look at what is known and hopefully spark conversations with clinicians. So I'm very happy to be working on this project. And, hopefully what we'll do with this is be able to ensure that the recommendations by the CDC and by these bodies that kind of guide our own clinical practice suggest we should do, I'm hoping that we can encourage those conversations to take place.
Awesome. Thank you very much for summarizing that.
Oh, I can't hear you, sadly.
Oh, you can't. I'm talking. It's lighting up, so somebody's hearing me. Okay, so thank you very much, Katie. We appreciate your summarizing that. And believe me, she can talk for hours about that topic. And we will be back at another breakout, and we will address any questions that anybody has. Lauren, are you able to speak yet? Okay. Well, hopefully Lauren is continuing to work on that, and I'm going to go ahead and jump in with my 2 cents. I am Jennifer Corcus. I am a women's healthcare nurse practitioner. I'm on faculty at University of Delaware. I teach in both the undergraduate program and the graduate program. So I help make BSN nurses and also DNP and MSN nurse practitioners. So I get them across the spectrum, and it's a great opportunity to really make a difference in healthcare in Delaware. So I've enjoyed getting to know the school and the students. I'm here today to talk to you about empowering women and my program that I have helped to develop in conjunction with the Professional and Continuing Studies Department at University of Delaware, and also with Christiana Cares Health System. We have a birth companion certificate program. So we take students that have at least completed their first semester of their sophomore year, or they could be a junior or a senior. And we take students that have a particular interest in maternal child health, and they go through an intensive 2-day workshop to train them to become what we're calling a birth companion, what you guys probably know of as a doula. And they go through a whole semester of different courses about communication and reinforcing childbirth education. And they really learn how to communicate with their assigned birth parent. And each student gets assigned a birth parent to work with through pregnancy. Our goal is for them to have 3 prenatal visits with them, then be there at the delivery to support them, and then to follow up with them for at least 1 postpartum visit. And so by doing this whole process, they become a Christiana Cares certified birth companion. And if the student elects to, they could go on and fulfill the requirements for national certification. And a couple of them have gone on and done that. And we've also had several that have gone on and interviewed and chosen to pursue labor and delivery or women's health related care after they graduate. So what we do is we sign up a cohort each semester, and we're on our 2nd cohort now. And we have the ones who completed the program in the fall kind of help guide and mentor in some ways the students that are going through the program now. And the first cohort, we ended up with 10 that completed the process. And this cohort, we have 16. And I haven't looked in the last 2 days, but we were tracking right along at like 8 or 9 births so far this semester. So they're doing it. They're really enjoying it. They're getting out of their comfort zone because so many of them have not had this kind of material in their studies yet, and they're very excited to be involved with the program. So I'm going to stop there. It looks like we have Lauren, and we'll let you jump in and talk about your initiative.
Sure. Hi, everyone. Sorry about my technical difficulties and being able to get on. I figured it out. So actually, I think that this order actually works better because my work, we kind of started with pre-conception and then, the birthing process. And my work is focused on how to improve sleep in families. Specifically, I look at it in early childhood. And so I just want to provide you some background on, poor sleep health in under-resourced families, and then some tools that we can use and provide to families to try and help to improve their sleep. So 9 out of 10 children are not getting sufficient sleep in the US. So this means they're not getting adequate duration at night. They're going to bed late. They're having inconsistent bedtimes from night to night. And this poor sleep in children is associated with many negative cognitive, affective, physiological, and behavioral effects, such as impaired executive functioning, negative mood, increased nocturnal blood pressure, poor dietary choices, decreased physical activity. I could go on and on and on with a list of things. All of these effects individually and concurrently substantially impair health, well-being, and thriving in our children. And the negative effects of poor sleep health and its negative health consequences are disproportionately experienced in children living in families with low socioeconomic status. And then poor sleep health in childhood, along with its negative health effects, tracks into adolescence and adulthood. So addressing poor sleep health in children, particularly children living in under-resourced families, represents a critical public health need that could also advance efforts to ameliorate health disparities. So the reasons for poor sleep health in under-researched and children from under-resourced families is multifactorial. The socio-ecological model helps highlight the multi-level barriers that contribute to poor sleep. For example, at the individual level, child health, such as physical or mental health disorders, can disrupt sleep. Or in younger children, having a sensitive temperament is associated with difficulty falling and staying asleep without parental intervention. Many caregiver factors are directly associated with child sleep, such as their own physical and emotional energy and the ability to provide a safe and secure sleep environment for their child. And then a caregiver's own sleep schedule and ability to regulate their own sleep directly relates to sleep regulation in their child, especially in the early years between mother and infant. At the household level, the presence of social and partner support directly relates to better child sleep health through the increased likelihood of being able to provide consistent sleep schedules for the child, whereas on the other hand, the presence of household chaos is associated with lack of structure and bedtime routines, which is detrimental to child sleep. And then finally, at the environmental or community level, living in an urban, noisy neighborhood with bright street lights, that's associated with poor sleep quality in adults and children alike. And similarly, household overcrowding is likely in under-resourced homes, resulting in the increased likelihood of bed and or room sharing. And so the presence of these factors and others that I didn't even mention will vary between families, and thus they need to be considered when providing tools to families to improve their sleep health. And I believe, and my work is showing, that addressing barriers to sleep health needs to be attainable and individualized for each family. So we know that consistent bedtime routines and sleep timing are crucial for obtaining adequate sleep duration and quality on a nightly basis. So how can we help families achieve this? Well, first, we can provide education to caregivers surrounding the importance of down-regulating bedtime routines. The American Academy of Pediatrics recommends something as simple as the 4 Bs, which includes bath, brush, book, bed. So making sure to discuss with caregivers how activities such as intense play or screen time will not help the child relax into sleep. Whether, whatever the activities a families decide to do, they can start them 30 minutes before bed. And then the order or the type of activities they do on a nightly basis doesn't matter as much as having the routine occur around the same time on a night-to-night basis. That's what's going to ensure an early and consistent bedtime for the child. So, let's think out some scenarios that could happen in families. Let's say the primary caregiver isn't home during the child's bedtime because they're working or caring for another child or family member. We could suggest that another caregiver, such as an older sibling, grandparent, or a neighbor, could step in and do the nightly routine with the child. Or let's say the caregiver is just maxed out in terms of their emotional and physical energy, and they don't have the patience or ability to be emotionally available to the child during bedtime. We could provide them with some quick, mindfulness-based techniques or coping skills to deal with whatever might be stressing them out in that moment. Let's say the barrier to sleep is resulting from the sleep environment. It's noisy, it's bright. We could provide a sound machine or even use a sound machine app on a smartphone. Blackout curtains are another quick and easy fix that we could provide. If the environment's too hot or cold, we could provide extra blankets, a fan for the sleeping space. If bed sharing is a necessity because of lack of room or being able to afford a crib or toddler bed, or even if it's the family choice to bed share, then we can provide guidelines on how to do so safely to reduce the risk of SIDS in infants. So really, my take-home message here is that we can't change all of the barriers that under-resourced families may face in regards to sleep. We can't change a lot of the stressors that they're facing on a daily basis, but what we may be able to provide them with are techniques to cope with such stressors and concrete solutions to deal with possible environmental issues. We can provide them with a toolbox of quick solutions that they can pick and choose to use on a nightly basis. And this has the potential to be helpful to multiple families who face different issues when it comes to getting good sleep health for their child and themselves. And so now we just want to open up the opportunity to answer any questions about, any of our work that we've been doing at the school. And, we're happy to have a discussion about these different topic areas.
I do see one question already, and I'm going to go ahead and read it out loud so that everybody can know what we're answering. It's from Jennifer Pulcinella. How do you get 18-year-olds to a doctor to talk about reproductive health? Pap smears aren't done till later, so now they won't go until there's a problem. That's for Katie. You're muted.
Won't let you unmute. All right. Well, I see a question for me that I can jump in and answer as you're trying to figure that out. All right. So I was asked, what are recommendations for working families? I have many families who have to work until midnight, pick up their child from the sitter when they are sleeping, but are stimulated on their way home and have to try to get their kids back to bed when they get home, which doesn't happen right away. Yes, I mean, this is an issue that I'm certain many families face. And this isn't just, a situation that could be present in lower SES families. I mean, this could be across socioeconomic statuses. And I think, an ideal situation would be to see if it's possible to have, social support is directly linked, and it's been looked across the life course with better sleep outcomes. So, it seems like they have, a support person, but in another household. So, an ideal situation would be if someone could come to their home, and so that the child could be put to bed in their own sleep environment. If that's not possible, then things such as, using a sound machine for the transfer. So when they're picking up the child from the other house, have a sound machine that's turned on at that moment, and then continue that sound machine through the transfer into the crib. If the child does awaken, which is very likely, I mean, I have an infant at home. I've yet to do a successful crib transfer from car to crib. If that happens, then, doing down regulating activities pretty immediately to try to get that child to bed within 30 minutes of getting home. But, obviously, this isn't going to happen every single night. You're not always going to be successful, but I think, just working with the family to kind of think through different scenarios that could potentially be helpful can kind of, they can pick and choose and determine what might work for them specifically. Thank you for that question. It was a great one. Any luck, Katie? No? Okay. All right. Are there any other questions? Okay, so Jen, looks like a question just came in for you in regards to the birth assistant program. How do you instill trust between the parents and birth assistants, seeing as they are most likely teenagers with limited experience?
Well, from the beginning, they introduce themselves as, learning, and they let them know that they do have a mentor behind the scenes. We work very closely with the maternal child education department at Christiana, and they've got lots of resources. And so the students are comfortable saying, I don't know the answer to that, but I know where I can look. And, if there's some question that stumps them, they come up. But part of it is just meeting them ahead of time and um, establishing a relationship. And so our goal is during those 3 prenatal appointments that they can actually accompany the birth mother to the medical appointment and be there and hear, what is directly told to her, and, maybe help with the clarifications, or maybe if she doesn't remember something when they walk out of that appointment. And so they're not just coming in when the birth mother goes into labor and shows up in labor and delivery. It's already an established relationship. And a lot of times the birth companions can even work with them while they're early in labor and help them to progress and to be comfortable in their own setting. And so it's kind of a process, and the students are learning about that communication and establishing that relationship. So we have had a couple of speed bumps where like a birth mother might have forgotten to let her birth companion know, or maybe the birth companion got to labor and delivery and for whatever reason, she was not able to participate in the labor process. So we are working on those things. And I think each semester as we offer the course, it's going to be a little bit different, and we're going to be able to forecast some of the challenges that we've had and maybe keep them from happening again and again. Thank you for the question. Anybody else?
I'm back.
Yay.
Can you hear me? Yeah. Oh, Jen.
Oh, it's okay. Go ahead. Do it without me.
Jennifer
She can
had
hear
a
you.
great question about, let me go back to it. How do you get 18-year-olds to a doctor to talk about reproductive health?
Now you're muted again, Katie. Yeah.
Too bad we're not better at reading lips.
I know. There you go. There you are.
Okay, there I am. I don't know what happened there, but I'll make it quick. So essentially now a lot of young people are receiving their reproductive health contraceptive counseling through the school system here in this state. So we have wellness centers that are available throughout various schools here. And I would say that that's probably where the majority of young people are getting this information. But I would encourage anyone who's a parent here, if you're thinking about it, to have these discussions with their pediatrician as you're going for your routine visits, because certainly they should be familiar with this information. They have access to it through, like I mentioned, ACOG and the CDC. So those are 3 great resources, I think, along with Planned Parenthood and some other resources throughout the state. And I know that I know we're getting short on time. So if anyone has a question for me, I'm happy to provide my information to answer any other questions that people may have. Thank you for dealing with my technical difficulties.
Yes, please reach out to us via email if you have any other questions. Happy to answer.
Thank you all. Enjoy your day.